Awesome. Thanks so much, Corey. We have a really awesome talk for you all today about caring for medically complex young adults. And there's a couple of us on the call, so I just wanted to give everybody a chance to introduce themselves. But I'm Sam, I'm a second year Med Peds resident. And Michelle, if you want to introduce yourself.
Yeah, hi everyone, I'm Michelle. I am a third year pediatrics resident.
And Eleanor, you want to introduce yourself too?
Folks, I'm Eleanor Floyd. I graduated from the Med Peds residency here a couple of years ago, and I run the Adult Special Care Clinic at Children's, which is our primary care clinic for very medically complex adults. So I'm so excited that Sam and Michelle are giving this talk because I am looking forward to the day when all of my patients come to you guys for all of their inpatient admissions.
Awesome. And then Chris, I'm not sure if you're on yet.
I'm here. Okay. So hold on one second. Can you guys hear me?
Yes.
Okay, good. Sorry, I thought my speaker was off, but this is Chris Peyton, and I'm one of the nurse practitioners that works with the REACH team, and I'm very excited about this as well. As we see a lot of these complex young adults that have not quite transitioned yet over to university, and we have a lot of conversations on our team on how to help with that transition and start these conversations as well too with goals of care and advanced care planning.
Awesome. And then if anybody hasn't filled out the survey yet, we put the survey in the chat and just hoping to hear from you about where you're coming from on this topic before we give this lecture. So if you want to fill out that survey real quick, we would really appreciate it. So why are we talking about this topic today? So from preliminary survey data we sent out to the medicine residents, we came up with these 6 conditions, which are some of the more common genetic and congenital conditions that we see children and adults with in medicine. And on average in the IM program here, most residents had only seen 1 to 2 of these conditions throughout residency. And these are conditions that patients are regularly surviving into adulthood with. And so we think it's really important to have exposure to these types of patients and know how to take comprehensive care of them. And then just other data from our survey that we sent out based on the responses we had last night. So we asked about confidence with doing some of these more inpatient medical care activities to take care of complex young adult patients. And so you can see here for these different activities, so ordering feeds through G-tubes, airway clearance orders, ventilator orders and care, reaching out to pediatric providers, and developmentally assessing our young adult patients. For all of these questions, medicine residents strongly disagreed, or did not agree or disagree about whether they could confidently and independently perform these tasks. So this is why we're talking about these things today. This is going to be one of several lectures in this series, but our learning objectives today were to talk about key questions to ask when you're admitting a patient with who has a medically complex history and is a young adult. We also want you to become more comfortable assessing the developmental and cognitive abilities of complex young adults. We want to highlight some of the unique events of goals of care conversations with medically complex young adults, and then also describe the medical care structure at Children's and how when you are inheriting some of these patients who have recently transitioned, how you can talk to their prior providers and find the people who know a lot about them for further resources. So I'm going to hand it over to Michelle to go through our first case.
Excellent. Thanks, Sam. And hopefully these cases and this presentation will be interactive. So feel free, if any thoughts or questions come up, to unmute yourselves or comment in the chat. So our first case is a 22-year-old male that you're admitting on the inpatient service. Has a history of cerebral palsy, G-tube dependence, as well as chronic tracheostomy and ventilator dependence. He also has a history of multi-drug resistant infections and is being admitted with a fever and probably a urinary tract infection based on his initial UA. So in addition to the normal HPI that you would probably ask any other adult patient, not that I'm an expert at that myself, but what additional history would you think you might obtain specifically for this patient given some of his medical complexity? So if folks just want to chat it or unmute, whatever works for y'all. Awesome. So current home vet settings. Yeah, so you're going to need to be able to figure out what his ventilator is and if you're going to adjust that. Functional status, special needs, developmental history. That's excellent, really important. We'll talk a little bit about that, as well as if he has a caregiver and what does that look like. Excellent. Love the kind of discussion more about antibiotic use and how to target antibiotics most effectively for him. And then indwelling tube cares. So you guys are really highlighting a lot of different aspects in terms of equipment, as well as kind of just getting to know your patient. One strategy that that can be helpful is to really think of the patient head to toe. And so some of the specific features that, all of these kids or young adults, I guess, are unique, but some of them have somewhat similar kind of pieces of equipment or things that you should at least question and think about if your patient has it. So from a neuro perspective, we think about asking about a baseline neuro exam and functional ability. I think this is really important. Even just last week, we had a young adolescent female admitted to peds with the developmental delay, and nobody realized that her current baseline of like being nonverbal was miles from the mild developmental delay she had. So her care got really delayed because of that gap. And so really getting a sense of what is their baseline and are they at their baseline or not is really critical. Seizure types, as well as medications or VP shunts many of these patients have, which we'll talk about more in a future lecture. Tracheostomy, ventilator settings, or if they're on just home oxygen, and airway clearance regimens, which again is going to be another talk. And then G tubes, like somebody brought up, which we'll talk about in a minute here more. And then GU, so some of these patients are on a regular kind of catheterization program. So asking about who does the caths, how often, or how they void, as well as bowel regimens, as many of these patients struggle with chronic constipation. And so that's really important to stay on top of. And then from an MSK perspective, some of these patients have other like spinal hardware, hip hardware. So asking about those kinds of things, especially when you're considering infection sources, and then mobility needs as well to help your patient. So this patient, the mom tells you that he's vomiting. He's vomited a couple times today, and she held his most recent tube feeds due to this intolerance. So what specific questions will you guys ask regarding this patient's diet and this feed so that you're prepared to order what he needs during this admission? Excellent. Formula type. Timing, beautiful. Yeah, great. So how is it administered? What are you administering? These are all great things. And ask your friendly RD. That's wonderful. Oftentimes these patients come in the middle of the night and then it gets a little challenging, but good to remember that you have an RD. And Nutrin is a great type of formula. So just kind of reviewing a little bit about G tubes. So these are some different pictures, which you all may have kind of seen of the actual G-tube button there. And so one really important distinction to realize is your patient actually have a G, meaning gastric tube, or do they have a jejunal tube? Because feeding tubes can go either, and certainly G tubes are probably more common, although in the pediatric world, we see a lot of kids with jejunal feeds because oftentimes those are easier for kids to tolerate, but it's really important to realize where the feed is going. And some patients actually have this combined tube called a GJ tube, meaning that there's both a gastric and a jejunal port, which you can see in the upper right corner of the screen there, as well as in the actual diagram showing the gastric port right below that, and then the extension that goes down into the jejunum. And so it's really important to think about where your feeds are going. And the reasons that this matters when you're thinking through for your patient, one is gastric accommodation, and sometimes that can be affected in illness. And obviously that's relevant in G tubes. Absorption, so certain medications as well as vitamins are absorbed in the jejunum versus the stomach, or are not absorbed if you give them like transpylorically versus in the stomach. Aspiration risk. Some children with G tubes also have Nissens to help with the aspiration risk. And jejunal feeds themselves should also decrease the aspiration risk, because in theory, you should not be able to vomit that up. And if you have a patient who's supposed to be having J or jejunal feeds and is vomiting formula, you should probably be concerned that the tube is not in the right place, as sometimes that tube can get flipped up inappropriately into the stomach. Bolus versus continuous feed. So this gets at timing, but you cannot bolus the small intestine. You can only bolus the stomach because there's no accommodation in the small intestine. So you have to do continuous like 24-hour feeds in the jejunum. You can also do venting of the stomach at times if they have a gastric port. I already talked about misplacement of the tube, and then the ease of replacing a tube. So a patient who has just a simple G tube, it's very easy to replace. A patient who has a J tube, that is more of a surgical or IR type procedure to get it back in the right place. And so in summary, a really important question you can ask to get to the bottom of all of this is just, where do you put is number one, do you actually have a G versus a GJ versus a J? And then if they have more than one, because some people have the combined GJ, or some people have a separate surgical G and a separate surgical J with two separate buttons on their stomach, you can ask them which one you put your feeds in and which one you put your meds in, because oftentimes it's different. And for absorption of certain meds, they'll put them in the stomach, even if they're getting their feeds through the jejunum for better tolerance.
Just to add to that, Michelle, so an easy diagnostic test you can do is just a KUB to assess the placement of the J tube if you're worried that this has come out of place. And just like placement for an NG tube, this is easy to assess on X-ray.
Excellent. Do you want to go to the next slide, Sam? And please jump in if people have any other questions or experiences to share. So then, like you guys mentioned, you want to ask about the formula type. So usually formulas are labeled as like Nutrin or Jevity or something, and then there's like a caloric density number afterwards, so like 1.2, which tells you like the calories of it. Or 1.5 or whatever. And then the G versus J, we already asked about the volume of feeds you're giving each feed. Of course, and then bolus versus continuous and the time over which the feed is given. So if they're bolus feeds, it might be like 300 milliliters over 30 minutes, 5 times a day or whatever, versus continuous is just going to be like continuous 24 hours a day at 60 mils per hour. And then oftentimes there's a separate, so you want to ask about this because the caregiver or the patient may not necessarily think to tell you when you ask about feeds. Ask about water as well, as many of these patients have separate kind of additional free water needs that they'll flush with, or they're wired in or something like that. And you don't want your patient to get dehydrated, especially if they have like tracheostomies and such, because it leads to really thick secretions that can cause problems. And then also, don't forget that like many of these patients may take things from mouth. Many of them may have aspiration risk with oral feeding, so they'll have nothing by mouth, but some of them may take things by mouth. They may have special limitations of what they can take by mouth. And so you can certainly ask if they take by mouth and allow them that if you feel it's appropriate during the hospitalization. And then of course, at the bottom line, ask your friendly dietitian for help. This is just an example feeding regimen that you guys can look back at. These slides will be posted, but usually how things are kind of worded based on what we discussed already. And then this is, so what options, so if your patient's coming in, so they're on like home bolus feeds during the day, and they're having trouble vomiting their feeds, what are your options for getting this patient nutrition and hydration while they're in the hospital? How can you adjust things? Any thoughts? Yeah, awesome. So I think the main suggestion is slowing down the feeds, which is a great thought. So that's something that's really easy to do, is slowing down the feeds or giving like smaller boluses more frequently, or doing continuous feeds, any way that just kind of makes it be easier what they're getting on their stomach. And then you can also consider, this is something we do a fair amount in pediatrics, is like diluting the feed. So sometimes kids do better with, or I guess adults as well, do better with like Pedialyte than actually tolerating the formula, just like anybody who's sick would. And so sometimes you can save yourself from having to do IV fluid and dealing with some of the consequences of that by just putting Pedialyte through their gut. Or sometimes we even do like a diluted, like 1-to-1 version with Pedialyte and feeds to make it easier to tolerate. You can also vent the G-tube. And so that's what this movie in the corner, Sam, if you want to just play it, is showing. And so a lot of families will vent, and you can kind of ask them about that, like in between feeds or before feeds. And so they kind of connect it to a syringe and help to get some of the extra air out. And some people will be continuously vented, and they'll just have that connected all the time, especially if they're getting fed like through the small intestine, they can vent their stomach all the time. So sometimes venting is helpful. And then of course you can always make them NPO on IV fluids as well, or TPN as was suggested. And I think something that Sam mentioned to me is a difference between pediatrics and adult medicine is most of our patients that are NPO for any duration, really more than a few hours of time, go on IV fluids. And so just thinking about that, that's not necessarily something that all of these patients are going to need, but especially if they're more kind of need the fluids to keep, if they have a trach, an event, and they have a lot of secretions and airway clearance, a lot of times keeping hydrated can be really helpful for that. And just thinking about some of these more complex things too. If you have a patient with metabolic issues, oftentimes they need really high dextrose containing fluids or special fluid needs. So make sure you talk to the metabolics team or your dietitian about those kinds of things. And then also just being careful when you start IV fluids, if it is a smaller patient, as some of these folks are kind of below the typical adult size, you might consider doing a slower rate of fluids. And there's kilogram based calculations that we usually do for that in kids, which I'm sure this calculator also can help you all with if appropriate.
Great.
You want to go ahead, Sam?
Sure, yeah. So just want to pause there for a second. Any questions about G-tube feeds, maintenance fluids, things that we talked about? All right, well, feel free to keep sending in questions, and maybe Michelle, if you want to just monitor the chat, if there's any questions about that part of what we talked about, and we'll move on.
Eleanor just made that helpful comment that you can also consult the metabolics team at Children's. I don't know if folks saw that. So that can be a go-to for those young adults.
Awesome. And we have a slide at the end that lets you know how you can consult teams at Children's that are not available at university, if that's a service that you're needing for your patient. So we just scratched the surface with G-tube considerations and how to feed patients who are G-tube dependent. And so I think this can be a lot, and a helpful thing for our framing when thinking about these patients, or even when becoming frustrated with not knowing how to order G-tubes, not knowing how to feed this patient, not knowing why they're not tolerating feeds, is that this is a lot, and families do it every day. And often for this patient population. This is something that family's been managing for this patient's entire lifetime. And so we just wanted to slightly embarrass Eleanor, but put this quote that she said when we were preparing for this lecture, that no medically complex child makes it to adulthood with at least one person in their life who cares for them enough to sacrifice their own life and their sense of normalcy to keep this child alive. And I think that's just a really helpful framing when we're talking about the extreme level of detail needed to care for these patients, and to really recognize what caregivers have been doing for these patients, often for their entire lifetime. And so with that, we wanted to go to a second case. So for the second case, you're caring for a 23-year-old man with a chromosomal abnormality, epilepsy, and intellectual disability who's admitted with refractory status epilepticus. You're having difficulty terminating seizures on multiple IV anti-epileptics, and his prognosis is guarded. You want to initiate a goals of care conversation with this family. What are some things you might ask to get to know the patient and the family as either an intro to a goals of care discussion or just when you're doing your normal admission H&P? We already touched on some of these, but any suggestions of things to ask that are going to help inform a goals of care discussion, either now or in the future during this hospitalization? Awesome. What does he like to do? Things you enjoy doing together. What does his day look like? Awesome. So I'm hearing lots of open-ended questions. And I think a lot of this depends what type of patient you're talking about. But just some other questions to elaborate, things that you can ask to get to know your patient. And I think really important things to ask are, how do they communicate with you? Is this a patient who can talk and express their needs, or are they generally using a device to communicate or can't communicate at all? How do you know that your child, your adult child, is in pain? Also a very important question to ask that I think is going to be really key for assessing what level of distress this family might be in, or the patient might be in, regarding their current hospitalization. What does a good day look like for this patient? And then technical questions like, what is their heart rate usually? Do they use this piece of equipment at home? What's their normal blood pressure? Things that these patients who are frequently hospitalized may know and may be really helpful to you as you're considering, are they septic or are they usually just more tachycardic than I would expect? Have they ever been hospitalized with the same problem before? And then what's worked previously for them for this problem? And then another question as you start to get closer to the goals of care end of things, but have you been told before that your child may not survive? And I think this is a really illuminating question. And I think more people will say yes to this question than you may expect, and may be really informative when families are not communicating goals of care in a way that seems familiar, or how you think that you may have answered these questions. This may be one of many scenarios where this parent or caregiver has been told that their child may not survive. Alrighty, so then just to help with getting to know patients, we wanted to talk a little bit about developmental assessment that can help us get to know what are the capabilities of our patients, and what can we expect them to communicate with us or not be able to communicate with us. So I was just going to mention a couple of milestones, and this is a little bit more PEDS, but maybe you can remember back to step 1 or step 2. And I was just going to give a milestone that a patient may achieve early in childhood, later on in adulthood. And then if you can just take your best guess at what age we would typically expect this milestone. So for the first one, let's say your patient is able to point to an object that they want. What age do you think that a typically developing patient would be able to do this? 4 months. Okay, any other guesses? One. Awesome. Yeah, one is a really good guess. Yep, that's probably typical. But really important to know about some of our patients, like can they point to an object that they want? And is that the highest level of communication that they can express to us, or are there ways that we can elicit their higher level communication? In terms of a motor skill, when would we be able to, or when would we expect a normally developing patient to be able to sit up on their own? Six months, awesome. 4 to 6 months. Perfect. Yeah, you guys are right on it. So yeah, 6 months is about normal for development, but as we're pointing out, this may take many more years for some of our patients to be able to do some of these motor skills, or they may not be able to do some of these motor skills, and that would be really important to know about the patient, and may increase our risk of ulcers or other skin breakdown that we'd be considering on the differential. Um, all right, and then so we just wanted to point out that there's this CDC developmental milestones resource that's available, and less so for deciding an age that this patient has skills at the level of, but just to consider that these different areas of development are really separate categories. And although some of our patients may not be able to sit up on their own, so not at the level of what we would expect from a 6-month-old, they may have really advanced social and emotional abilities and or language and communication abilities. And so it's really important to be able to separate these different components of development and consider in each category, what would I expect my patient to be able to communicate to me? What is their baseline? And then what are they currently able to do with their more acute illness that's bringing them into the hospital? And just to emphasize, I asked a patient one time, or I asked a parent of a patient, what is the most important thing to know about your daughter? And she said, my daughter's insightful and creative, but when people look at her, they assume that she doesn't understand what they're saying. And so I think it's really, really important to separate the physical abilities of a patient from the cognitive abilities of a patient, and understand that they may have severe limitations in terms of physical abilities in some cases, but that does not necessarily affect their cognitive abilities. And so when we're not sure, just asking the family about those things, or assuming that the patient is able to understand everything that you're saying and speaking to them, addressing them by name, and assuming that they can participate in their care if we're not sure. Okay, and so then moving on with our same case, this 23-year-old man with epilepsy who is in refractory status epilepticus. So we're thinking of initiating a goals of care discussion with this family, and just want to consider what are the ways that this goals of care discussion would be different for this patient versus, let's say, a 70-year-old veteran with terminal cancer, who I think is a more typical patient that we might encounter a goals of care discussion with on internal medicine. So what ways can you think of that this goals of care discussion may be unique? Okay, awesome. Level the patient can participate in the discussion. may be true for many of our adult patients too. If they're intubated and not able to participate in discussion, then we may be encountering several of the same things. Unnatural for a 23-year-old to die, whereas we naturally accept a 70-year-old's death as more natural. Yeah, absolutely. So I think this can be really hard for families to consider that a 23-year-old's life may be nearing the end. Other considerations? Alrighty, so some things that we came up with, and Chris, feel free to chime in if you have additional things here. So previous life experiences may be quite different for this patient population versus a 70-year-old patient. So I typically start a lot of adult goals of care discussions with, tell me about things that were important to you throughout your lifetime. And those types of things may be quite different. It's maybe different in terms of career, life experiences, time spent in and out of the hospital. Maybe some of the best memories that this patient has are times they spent with their family while in the hospital. Maybe it's outside of the hospital. Our patient population may be less likely to have children or a spouse who is able to speak for them or to know details of what's been important to them. I think often medically complex young adults have spent a lot of time with their immediate family, but may have more limited relationships outside of the family than a 70-year-old who had 70 years of functioning and interacting outside of the hospital and a medical system. And then I think our own biases about quality of life are really important to consider here. So I think there's lots of good evidence about physicians really underrating the quality of life of patients who have been chronically ill and spent a lot of time in the hospital. And so considering how that might bring our own biases to these types of discussions. Medically complex young adults may be have varying abilities to articulate their end of life wishes, as well as abilities to articulate joy, sadness, pain, or similar things. And I just want to highlight that this may be a less ability to articulate these things, but not to experience these things. So our patients may not be able to say, this is what brings me joy, but most likely there are many things that still bring them joy, sadness, and pain. So finding other ways to elicit these things. As well, want to consider their prior level of independence versus dependence and what this brings to the conversation. So a 70-year-old who was previously independent and driving themselves everywhere may have a harder time with being bedridden in a facility. But if a patient has been dependent on a caregiver for most of their life, then this may not be a big difference for them if that's what we're considering in the future when we're talking about their goals of care.
And this is Chris Peyton. I just want to add some questions. I know it's a really good discussion on the chat with, I know someone had said about what does a day look like for you? To really go beyond that, we'll usually ask on our initial consults, tell us what a good day looks like and tell us what a bad day looks like. And that can really open up discussions, because really what you're getting at is the patient having more good days versus bad days, or more bad days versus good days. And that really kind of allows them to open up a little bit and really start getting about that quality of life. The other thing is too, is these readmissions, when they start getting more frequent, that is always a trigger, and usually one of the biggest triggers where we get an initial consult from the team to come meet with the family. Because besides these parents knowing and taking care of these young adults, they have become very savvy with resources and may have home nursing at home. They try to do everything to try to prevent these hospitalizations and really turn their home into a medical home. And when that starts getting disrupted with frequent readmissions, that is something that usually gets them to also start thinking about how much medical or surgical intervention they want to keep pursuing.
Absolutely. Thank you so much, Chris. And then just some other differences. While we may be able to prognosticate what a 70-year-old's life expectancy would be with a typical type of cancer, many of these patients have so many unique features that are unlike any other patient, that our ability to say or predict the future is even more limited than it is in other circumstances. And I think Chris touched on this too, caregiver burden. I think it's hard to make any assumptions here about what caregiver burden is or isn't. Going back to that initial quote of somebody has already dedicated their entire life to keeping this patient alive, and is what we are asking them to do something that they've already been committed to for several decades, or is this a new thing that's disrupting their routine and changing what this caregiver has been able to do in the past? And then just some resources to touch on quality of life. I think this is a really striking picture to me of a young man with cerebral palsy who graduated from high school. And I think addresses a lot of our biases as physicians about our able-bodied biases about whether we rate patients as having high quality of life, low quality of life. There are many unexpected things that patients can do and may not be the way that we think we would want to live our lives, but patients tend to rate their quality of life as much higher than we do as physicians. And so keeping these things in mind as we're going through these goals of care discussions and encountering answers that may be different from what we would typically see. All right, and then I'm just going to hand this over to Chris just to talk a little bit more through specifics of goals of care discussions for medically complex young adults. But we wanted to put these resources in the PowerPoint so that you know who you can reach out to if you are taking care of medically complex young adults. So the REACH team is the first number listed here, which is Peds Palliative Care at Children's Hospital, which Chris is a part of. The special care clinic is the primary care clinic at Children's Hospital, where many of these patients were cared for all of their childhood and may continue to be cared for as adults. And many of Eleanor's patients are here as well. And then Children's One Call. This is probably the most important number on this slide. If you call Children's One Call, you can be connected to any children's specialist. And so that's including the metabolics team, the genetics team, and other consultants that may not be available at university. And you can also call this number to be connected to special care or to the REACH team. All right, Chris, and then we have some of your slides, or do you want me to hand over the screen share to you?
You can just go to the slide. Yeah, if you go to the next slide. Yeah. Thank you, Sam. So I just wanted to give one of the things that we really try to promote, and our team is really small here at Children's, our REACH team. At university, they have a much bigger palliative care team, but we try to share what we call primary palliative care skills because obviously we cannot be present and available for every discussion with families where you may have to deliver some poor prognostic news. The other thing is too, going back to that first case study with the G-tube and the J-tube, one thing that I have found is that is a much bigger decision to have to convert to a GJ tube for a lot of families than I feel that we give credit for. To go to continuous feeds, it is in part usually by the patient and the parents as a failure of feeding, and they start to really get concerned about intestinal failure and possibly even becoming TPN dependent. So I feel that I've spent a lot of time in discussions with parents on that, and the teams are not understanding why they're pushing back so much on possibly a GJ conversion. So this is just a framework that we use in our world of the Ask, Tell, Ask, and I just wanted to walk through it. briefly, because really what you want to do is you want to assess their understanding. And once you assess their understanding, that really gives you more leeway to be able to have that conversation to move forward. So the first part is asking, and it sounds very simple, but just asking for permission to talk to the patient. And usually the patient does want their parents present, because even though the patient can be that decision maker, they are usually relying on their parent or parents to really help with their medical decisions. So for example here, I just put, I need to have a discussion with you and was hoping this would be a good time. Tell me what you understand about the last few days and information you have received from us. And that usually will allow them to tell you this information. And then that you move to the tell, which is you sharing that information. Now, here's what I know about your diagnosis. And I put on here, when we're really getting to that point of, this is more concerning, obviously talking about more code status, but I'm worried about CPR causing more suffering. And that obviously would be appropriate if they're starting to share with you things that are impacting their quality of life, and that by pursuing more medical and surgical intervention, it may actually cause more suffering than benefit. And then you want to finish by the asking, and you ask by assessing how the information was received. And this is really, saying to the patient, tell me what you understand by what we just talked about. And Sam, if you can go to the next slide. This ask usually is very uncomfortable because it is emotional for the patient and for the parents. And it can get very uncomfortable for you as the doctor or provider that's asking this question. So I just wanted to also talk about responding to emotion. And one of the techniques is naming it and saying, I can see how difficult this news is to hear. And acknowledging is, I can't imagine how hard this is for you and your family. And the wishing, and I have to say, I feel I use wish a lot with parents and patients, and it is generally well received. I wish things were different, but this is what I recommend. And the other thing I'd like to add is silence is really important. You have to give time for them to process. They will usually get emotional and sometimes even tearful, and it's so uncomfortable. I did a consult yesterday where we had to utilize quite a bit of silence, and it does usually give time for the patient or for the parents to eventually respond to you, but it can take a while. And like I said, it's very interesting to me. I am currently enrolled in a Harvard PSEP course that was really kind of delayed because of the COVID and everything going on. I was supposed to go to the second part in April, but I was in a group with physicians that were all wonderful, but it made me realize they were so uncomfortable with silence, and even talked about how they just didn't feel that it was appropriate to use silence. And as being someone who, I've been a nurse for 30 years and a nurse practitioner for 20 years, but in our nursing background, that is one of the first things we learn as a communication, is to use silence. And granted, we're at the bedside, 12-hour shifts. And it was really interesting to me because when we had to role play with patients and we started using silence, which I was more comfortable with, the doctors all looked at me and they said, how did you do that? Like, how did you just stop talking and sit there? It had to feel so uncomfortable. And it can be uncomfortable, but once you get used to it, it really is very, very effective in just using silence when you're having to have prognostic conversations. So, and I guess I wanted to ask the group, how you feel about that, and if you've been in that situation where it's gotten awkward and silent and you weren't quite sure what to do about it.
We might have an awkward silence
I
while
know,
we wait for
exactly.
comments about silence.
Yeah.
Respond with silence.
Silence,
Yeah. Yeah. But I think many of us have probably been there with that uncomfortableness with silence. And I think many of the people on this call have gone through several goals of care discussions before. And so I think if you're in the situation where you're approaching a family or a patient who's a young adult with complex medical needs, just keeping in mind the ways that your normal ask, tell, ask that you're accustomed to may be more difficult, more nuanced, may have more emotion associated with it than goals of care discussions you've had before. And I think being very purposeful about these steps when you're in a more difficult or more emotionally laden setting is even more important.
Yeah, and I would say too, I know so many of us right now, time is such a factor, and you can have limited time. And so really, I think the most important thing is really assessing that understanding, because a lot of times when you're going in for a goals of care discussion, what you think you might be focusing on for goals of care can be very, very different depending on what their perception and understanding is of what they've been told. And that really can help. There's so many times where we do consults where I'm like, just so surprised. I'm like, I did not think we were going to go down this path. And it really changes that framework. And it gives you permission, besides you asking for permission, it gives you permission to be able to share and talk going down that path with them.
Awesome. So we just have a couple of minutes left, but just wanted to share with you some other resources that may be helpful if you're caring for medically complex young adults. So this slide is just a snippet of some of the specialty clinics that are available at Children's that may be helpful to you. Some of these may be more helpful for our adult patients than others, but definitely helpful to see some of the multidisciplinary clinics that our patients may be transitioning from. And several of these most of these clinics are multiple provider clinics where the patient comes to the clinic and then sees 3 to 6 specialties depending on the condition, and something that we don't really have replicated on the adult side as well, and certainly not to this extent. So just understanding where your patient is coming from, and then also knowing that these clinics are available to reach out to. And then lastly, we just wanted to highlight some of the future things we're hoping to talk about during Noon Conference about caring for medically complex young adults. So in 2021, once this crazy year is over, we're planning to have a session about specifically focus on respiratory care of chronic trach and vent dependent patients. We're planning to have a session on neurologic care, focused on seizure management for refractory epilepsy and care of hydrocephalus and specific types of shunts and complications. We have a couple of guest speakers to talk about guardianship and medical proxies in young adults with intellectual disabilities for some of these more difficult cases where it's not straightforward whether a patient should have a guardian. And then also planning to talk about treatment and prognosis for some common genetic and congenital conditions, and specifically highlight there's new adult treatment guidelines for patients with Down syndrome and several other treatment guidelines for other conditions as well. So planning to highlight those things in the future that hopefully will be really useful to you. With that, if anybody has any questions, we're happy to take any questions. If there's anything that you would hope for us to cover in future sessions, please send us a message as well. And thanks so much for joining, and thanks for participating.
Sam, thank you so much. That was an incredible talk. Actually, I had one kind of question that I wanted to ask. When you guys talking about how do you approach a goals of conversation with somebody who's got a complex medical history, and I had a patient who had Down syndrome, who was in their 50s, had multiple complications, recurrent aspiration, was not able to be weaned off of the ventilator, and we had to have the conversation with the caretaker who'd been with this patient for years about kind of goals of care, and to continue with doing a tracheostomy peg tube, or making this focusing on comfort care. And one of the things that I was always the most concerned about is I never wanted the caretaker or the family to feel like I was devaluing this patient's life, because of the quality of life might not be what I would assume is my potential quality of life. And I just wanted to see from y'all's standpoint, when you're having these difficult conversations, just is that something to kind of worry about with these families, or is that just me being overly sensitive? What's a way to approach it so it doesn't give off the impression that that we as healthcare providers are like not valuing them the same way as people who don't have as complex a history?
Yeah, that's a great question. Chris, I don't know if you want to take the first crack at that.
Yeah, so I think it really goes back to when you're asking about good days versus bad days, and you're really asking that family and the caretaker who's been with them, to tell me what what a good day is, and reflection of quality of life. And by doing that, you're acknowledging what they're defining as quality of life, because you're right in that, I was in the pediatric cardiology world for many years, and we had so many objective quality of life measures. And I really took a step back one day and I thought, well, why are we the ones defining quality of life with all these surgical database measurements, which are important, but it's what the family and the patient perceives. And it really goes back to that ask, tell, ask, and acknowledging what their, the quality of life is. And when you do that, they feel that you are listening to them and you're validating that quality of life. And that usually can be very helpful for them.
Yeah, I think that sounds great. And one thing that I've come across this month in the PEDS emergency room is sometimes I find myself asking questions more like, can your child talk? Versus asking questions like, how does your child communicate with you? And I think the second question is more open-ended and doesn't assume a baseline level of functioning. Whereas the first question is saying like, does this child meet this thing that I think they should be able to do? Which may be taken much differently by the patient and family. So I think just keeping our questions open-ended. And Eleanor, I don't know if you had something to chime in with as well.
Yeah, if you guys don't mind. Corey, I thought that was a great question. And I just wanted to validate your concern that people would be worried about your judgment of quality of life, not you personally. I know you, and I know that you are a very empathetic caregiver, but a lot of my patients' families have been dealing, sometimes even since before the patient was born, with medical providers who have told them that this is not a life worth living. So I think that all of the tips that Chris and Sam have given are super important, because I think one of the difficult things about a goals of care discussion with these patients that we don't typically deal with on the adult side, we're dealing with everything we would be dealing with another adult patient: the fear of losing someone, the fear of pain, all of these really complicated issues, but also a bunch of mistrust. So I think that's a really important question, and I'm really glad you asked.
Awesome. Any other questions? All right, great. Well, thank you all so much. We really appreciated your participation, and just let us know if there are any specific things that you would hope for us to talk about in the future in addition to this list, and we'll let you know when those next talks are. Michelle, Chris, and Eleanor, if you want to just stay on and we can chat real quick. Corey, if you want to stay and chat with us too.
Yeah, I'll stay on.
Awesome.